Tokyo, Japan, Dr. Mizuno.
Recently, total debranching TIVR has been widely used for aortic arch diseases, but some critical problems remains to be solved, such as stroke, spinal cord ischemia, and aortic dissection. The manipulation of the ascending aorta probably causes these complications. So in our institution, an axillary artery bypass is initially placed during artery vessel reconstructions. We think this method can reduce the risk of malperfusion and stroke. During the creation of the axillary artery bypass, direct contact with the carotid arteries can be avoided, so malperfusion and stroke can be prevented. And this bypass can perfuse the brachiocephalic arteries even when the brachiocephalic artery is clamped. And the blood flows from the distal part to the clamp site, so there's little possibility for debris to go into the brain. So in the last 1 year, 6 patients underwent total debranching TIVR using this method. The off-pump procedure was completed in 3 patients, and the cardiopulmonary bypass was used in the other 3 patients. We didn't encounter 30-day and in-hospital mortality and morbidity, as well as stroke and spinal cord ischemia. The inbox value didn't decrease during the reconstruction, except in one patient. But the inbox was quickly recovered by increasing the blood pressure. But localized aortic dissection occurred at the proximal anastomotic site in a patient with the dilated aorta on the 7th post-operative day. So we replaced the ascending aorta. The mean follow-up period is 14.2 months, and we didn't encounter midterm mortality and morbidity, as well as aorta-related complications such as end weak and migration. We can use simple clamping of the brachiocephalic artery, but it carries the risk of malperfusion if some unfavorable event occurs. And a perfusion catheter also can prevent malperfusion, but the catheter also carries a risk of stroke. Even using this method, partial clamping of the ascending aorta can't be avoided, especially in off-pump total debranching TIVR. So the manipulation of the ascending aorta causes the stroke and also aorta-related complication. So if the ascending aorta is dilated or has atherosclerotic lesion, the ascending aorta should be replaced to prevent stroke and aortic dissection. Thank you.
Interesting study. In my experience of doing a few of these, I tried one off pump, I tried one with the pump, and had better results with bypass as it provided hemodynamic stability and cannulated with right axillary and could always perfuse the brain. And then when I did my debranching to the innominate, I would come off bypass or let the heart eject through the left carotid. And I found that worked well. Do you do all of these off pump? Are you selective?
So in this study, we did the off pump surgery in 3 patients, but some patients has previous cabbage or previous replacement of the ascending aorta, and it's difficult to clamp the ascending aorta, so we use the cardiopulmonary bypass. And this method maybe is very useful in off-pump surgery. But if we use the cardiopulmonary bypass, we have the method to protect the brain. So I mean the hypothermia and the perfusion method.
Anyone with questions? Okay, thank you very much.
Thank you very much.
The next speaker is